Once again, continuing with our project where we are keeping movement central to our semantic network or our network of meaning when looking at particular areas of anatomy. In this case, we're talking about pelvic side bending and rotation. Now, again, to be very, very explicit, I am discussing the pelvis in a way that is not consistent with the profession of osteopathy as far as its historical discussions are concerned, or even its present discussions, as well as the same thing to be said about the discussions within manual therapy writ large. And the rationale here is that the pelvis is not consistently known to move independently of itself side to side. So one side of the pelvis moving in relation to the sacrum or in relation to the other side. And it is very, very tied down with ligaments, as we noted in the pelvic flexion talk. So it does tend, outside of very, very small sets of population, to move as a unit. And I'm also not using the terms anterior pelvic tilt or posterior pelvic tilt, as the location of generation of those motions is primarily in the region of the torso. So really what you're looking at is lumbar flexion or lumbar extension. Now, in this case, we're also considering pelvic side bending and rotation. So we will simply say that really what we're discussing is lumbar side bending and rotation, because what you're talking about is, especially with side bending, approximation of one side of the torso, just make my hands work, do this, one side of the torso to one side of the pelvis, or one side of the pelvis to one side of the torso. In either sense, the generation of that motion is from the muscles that will actively move the lumbar column. Again, considering that the pelvis does not necessarily independently move side to side. So our main objectives here is to have a specific discussion of what pelvic side bending and rotation are. So planes and axes, a general discussion of the muscles that side bend and rotate the pelvic region, a general discussion of the nerves that supply those muscles, a general discussion of the muscles, the autonomic supply and vascular supply of the pelvic floor. So just a simple hint, mostly you're talking about the pudendal outflow, the pudendal neurovascular flow, and then a general discussion of the areas to assess and treat should pelvic side bending and rotation issues be suspected or reported. So our quick review of planes. So the sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body front to back. Axes tend to, or not tend to, axes are perpendicular to planes. So in the case of pelvic side bending and rotation, the rotation is going to be in the horizontal or transverse plane about a vertical axis, right? So you're going to get this motion, motion like this. Right. The frontal plane is, or the coronal plane has an AP or PA axis. So it's going to be side bending or rotation about that AP or PA axis. So again, really what we're talking about is, as the slide notes, although we're discussing pelvic side bending and rotation, we're really talking about lumbar side bending and rotation because that is where these motions are generated. So the muscles of pelvic extension, it does say extension on purpose rather. So you're talking about iliocostalis, longissimus, and spinalis as the more superficial group for extension. And then you're talking about the interspinalis, intertransversarii, rotatories, and multifidus, especially when contracting bilaterally. But in the case of side bending and rotation, what you're going to have is unilateral contraction. So in the lumbar region, for the most part, most resources are going to note that a muscle on a given side with unilateral contraction is going to side bend and rotate to the same side. The one exception to this happens to be the external oblique, which we'll touch on in just a moment, because the external oblique is noted to side bend and rotate to opposite sides, but everything else side bends and rotates to the same side as far as common resources with respect to the muscles are concerned. Now, within the osteopathic world, you're going to have a discussion about Fryette mechanics and type 1 motion versus type 2 motion. What I will very simply say is that the development of the Fryette mechanical model was more or less a dismembered spine, so it was missing a lot of context, and you're making assumptions, or it is making assumptions based on the general layout of facet joints, noting that, or not noting rather, that facet joints are variable on the same segment within the same person. So a lumbar facet, although mostly considered to be in the sagittal plane, may actually look like this on one side and like that on the other side. So you may actually see some variation side to side, such that assuming that facets are the same on every vertebrae within every person, or they match the description that is normalized between specimens or between people, is unfortunately inaccurate. It is more accurate to say it moves how it moves. And we are looking from the outside, therefore our view is obscured, or our understanding of motion is obscured in motion mechanics. So instead of maybe focusing on the Fryette model, we focus more on the motions that are observable, and we test them within their planes. And at least with respect to most of the muscles that will side bend or rotate the lumbar column, side bending and rotation in those muscles is noted to be to the same side. As far as muscles of pelvic flexion, so saying flexion on purpose, the rectus abdominis, the internal and external oblique, the external oblique being the muscle that is noted as a muscle to side bend and rotate the torso to opposite sides. So this is where the confusion comes in, whereby if you see opposite coupling, so side bending and rotation to one side, which would be your type 1 mechanic in the Fryette model in the thoracolumbar region, then you will assume it's normal. However, the vast majority of the muscles are noted to side bend and rotate to the opposite, or to the same side rather, such that it is actually at least a little bit more normal on the muscular side to see side bending and rotation to the same side. So instead of dealing with this confusion, what I would suggest that anybody would do is test each plane as its own entity and then respond to what is found. So instead of saying that if I find side bending to the left, it is obviously rotating to the right, you test side bending, then you test rotation, and you treat what you find as opposed to treat what you assume. So be careful with your assumptions based on any of these models. So even though the muscles are noted to side bend and rotate to the same side, in this region, aside from the external oblique, you should treat what you find as opposed to making assumptions and filling things in based on your preferential muscle. So if you really like the external oblique, you think that that's the most important, then you'll make the mistake of thinking that everything is dictated by the external oblique. Instead, assess each plane as its own plane and pay attention to free motion. So free motion is there, you don't have to do anything. If there is asymmetrical motion, then you have to do something. And you do something according to the asymmetrical motion that is identified, not the asymmetrical motion that is assumed by a model in your head. You pay attention to the patient instead of your previous assumptions and your previous knowledge, because most knowledge has errors that the knowledge itself or the knowledge generator is unable to detect, and that also applies to the person wielding it. So as practitioners, we often are making errors that we can't detect and we'll never know until something shows that to us or some sort of mistake shows that to us. So that is a large way to say, test each plane, and whatever your findings of asymmetry are, treat that as opposed to assuming prior or a priori that which can be known without sensing. Do not assume that because you have one finding, it means something else automatically. Test it all and work in that fashion. So just to make a quick note again, pelvic side bending is lumbar side bending. So it would be approximation of the left side of the pelvis to the left side of the lumbar region, or the left iliac crest to the left common costal cartilage is something that you could say. And then rotation would be the movement posterior of the pelvis in relation to a relatively still thorax. So what you would see is if this is the thorax and this is the pelvis, then you'd see that. If it was rotation of the lumbar column as some way to split it, then you would see a relatively still pelvis and a moving lumbar column, or you can see some combination thereof. But the motions or the location in which movement of the pelvis as a unit is going to be generated is the lumbar region. Now, as far as the erector mass or the muscles of the posterior region or the vertebral muscles and intervertebral muscles, look at the dorsal primary rami. So out of each related spinal segment or vertebral segment, the dorsal primary rami is going to go backwards through the region. It is going to innervate the muscles for motor tone, as well as innervate the skin very, very close to the vertebral column. So you've got motor tone and sensation coming from the dorsal primary rami. As far as the abdominal muscles, you're really talking about the intercostal nerves. So the superior attachments of the abdominal muscles, broadly speaking, happens to be ribs. Therefore, the intercostal nerves will innervate the vast majority of your abdominal musculature outside of the internal oblique, which is going to receive some tone from the upper regions of the lumbar plexus. As far as the lumbar, as far as blood supply to the region. With respect to the posterior side, you're talking about the lumbar arteries and veins. So the erector mass and the intervertebral muscles are going to receive supply and drainage, or are going to have related supply and drainage through the lumbar arteries and veins, which essentially mimic the posterior intercostal artery and vein. So they do more or less a similar thing. They go around the body wall and will send some branches back to the posterior surface of the body wall. As far as the abdominal musculature, you're thinking as high as the subclavian through the internal thoracic or internal memory before it becomes the superior epigastric. You're thinking all the way down to the iliac circulation, where it's going to give off the inferior epigastric, as well as to some degree, some of the lumbar arteries and veins, or some other circulation from the iliac region to supply the abdominal musculature. So if you're thinking about the vascular supply or the neural supply, again, and you're noting lack of motion in the lumbar or pelvic region or in the lumbopelvic region, and you're thinking about all of these things, then you're automatically thinking a very, very large area, which can be confusing. However, if you pay attention to the motion dysfunction that you find and you interface with that, you accurately interface with the problem at hand. If there happens to be a related motion dysfunction in an area that would be considered related to the neural supply or the vascular supply, then you have a separate finding, and they may relate to one another. However, if you pay attention to the motion dysfunctions that you find, you behave more accurately to the problems that are found with respect to the individual patient in the moment, as opposed to confusing yourself and increasing your cognitive load and thinking about everything else. But that said, the blood supply to these things is large, right? Or spans a large area. The neural supply spans a large area. Therefore, chasing that can actually be confusing and inaccurate to the problem at hand with the patient in the moment. Now, just looking at the pelvic floor, you can discuss the pelvic floor as individual muscles, or you can discuss it as a broad concept. So some people will call it the pelvic diaphragm because it is essentially the floor of the pelvic cavity. So it has some degree to which it is suspending the organs in the pelvic cavity, making sure that they don't fall outside of the body wall or outside of the body cavity. There's a central raphe, or more or less a central tendon, that's going to go more or less in an interrupted fashion from the coccyx forwards towards the pubic symphysis. Now, this is going to be interrupted by things such as the external genitalia and the anus. Right now, that said, it's not really that it's deeply interrupted. It just alters as it goes more or less around those structures. So these muscles in a sling-like fashion are going to attach to the body wall in the form of the pelvic bones, and then to the central raphe. And they're going to have mildly different functions depending on where their connections are, such as the puborectalis and the pubovaginalis. Those are going to have some control over the openings of those structures. And those sphincters tend to be the external sphincters, also the external urethral sphincter would fall under this. They are they're innervated more or less by the pudendal nerve, such that they are under conscious control. So this is why you can hold bathroom function, because you have conscious control of the external sphincter. So all of the autonomically driven stuff may be happening internally on the internal sphincter as well. But the external anal sphincter or the external urethral sphincter can hold the bathroom function to some degree and to some period of time. But more or less what you have is varying fibers going in varying directions, doing different jobs, but more or less they come together as a sling to a central raphe that goes from the coccyx to the pubic symphysis. Now, the things in this region that are going to do the most moving are going to be the lumbar column and the hips. Therefore, you can do huge amounts of work with respect to the pelvic floor by ensuring that the body wall, right, in the form of the lumbar region and the abdominal region, is moving as it should, as well as ensuring that the hips are moving as they should, because they are the things that will transfer large amounts of force from the leg or from the thigh into the pelvis. So those are your big hitters. There will be times where there may be value in attempting to interface with the pelvic floor. And what I will say is, in most jurisdictions, it is smarter to refer this out as an osteopathic practitioner, because it's going to depend on the laws that govern your practice. Pelvic floor physiotherapists in most jurisdictions are able to work with the pelvic floor. That's why they're titled as such. Whereas osteopathic practitioners are going to have varying regulations. So it is smarter to avoid the pelvic floor for the most part, because if you are unsure in any way of your regulation. So just generally avoid it. Now, that said, the only point where you can really access the pelvic floor as an osteopathic practitioner from the external surface is the ischial fossa, which is basically the space that is filled with fat between the ischium and the rectum. That said, you want to stay as lateral as you can, so as close to the ischium as you can. You need very clear, informed consent. The patient needs to know exactly what you're doing. Even if they provide you that consent, they can remove it at any time. And you want to be extremely sensitive to the area. It's very uncomfortable. It is very unlikely that you'll ever have to work here. If you think you do, it's smarter to refer this out to somebody such as a pelvic floor physiotherapist or somebody else who has the legal ability to work in the pelvic floor region. Most osteopathic practitioners do not, and I would suggest that most avoid it. If you are in a situation where there is reason that you are able to do this, then you work as close to the ischium as you can. You use your eyes and avoid the midline of the pelvis to stay away from the external genitalia. So again, the pelvic floor, you can just look at it as a sling that has varying functions on that central ray for that central tendon going from coccyx to pubic symphysis, or you can pull it out and say pubovaginal bulbospongiosis. You can say, talk about the iliococcygeus, the ischiococcygeuus, which is the coccygeus, and the levator ani, which is really two muscles. You can do all that, but it doesn't necessarily help as much as the more clear understanding is you've got a sling and your big hitters to deal with it happen to be the abdominal region or the lumbar region and the hips. Now, we want to talk about what supplies the pelvic floor. So we touched on this briefly when we talked about the male reproductive anatomy, but the pudendal nerve or the pudendal neurovascular flow. So superior or at the top end of the ischial fossa, you have Alcock's canal or the pudendal canal, where the pudendal nerve is going to supply the muscles of the pelvic floor, very broadly speaking. As well, with neural tone, it's going to supply sensation to the external genitalia in males and females, and it is also going to supply blood supply and drainage, or provide blood supply and drainage to the region. So you can see in the picture that you've got the nerve and the accompanying pudendal circulation. So it's going to be very, very lateral within the pelvic floor, and the place that you can identify it the best, or identify where it should be, because this will be variable person to person to some degree, is medial to the ischium. So if you ever have reason and legal right to work in the region of the pelvic floor, then you stay very close to the ischium and you don't go towards the midline, because that's where those structures are if you have to interface with them. But again, your lumbar column, your lumbar region, and your hips are much larger generators of force. They are much more likely to be the places where you should look to have some positive impact if there is a mechanical correlate to the presented concern in the reproductive regions for both males and females. Now, as far as the autonomic supply, the pelvis is the place where it switches in a fairly clear way, where the sympathetics more or less stay the same. So the sympathetics are, you've got sympathetic chain ganglia along the whole vertebral column, and they're going to have outflow to particular regions. Usually it descends somewhat, especially say with something like the splanchnic nerves. So you're going to have or the thoracic splanchnic nerves, you have lumbar splanchnic nerves as well. But in the thing that is common in most of the body is that the parasympathetic side is supplied by the vagus nerve. Now that cuts off in most cases at the distal third of the transverse colon, such that the descending colon does not receive any parasympathetic innervation from the vagus nerve. What does occur, however, is the parasympathetic outflow comes from the pelvis upwards. So you have the inferior hypogastric nerve or the inferior hypogastric plexus, the hypogastric nerve, which joins the inferior hypogastric plexus and the superior hypogastric plexus. And what that's doing is sending parasympathetic flow up. So when you hear about parasympathetic flow, last third of the transverse colon, distal, or the descending colon rather, and the pelvic region, what you're thinking about is the pelvic splanchnic nerves. They're called pelvic splanchnic nerve, and what you do is when you say pelvic, you think parasympathetic. Now, on the other hand, the sacral splanchnic nerves follow the general flow of the sympathetic system, because they will provide tone, sympathetic tone to the viscera and the body wall in the general region where they live. In this case, they do tend to ascend as opposed to descend. But what you have is sacral splanchnic nerves. So pelvic, or P, is for parasympathetic. Sacral, or S, is for sympathetic. So you have your general tone to all of the or pelvic viscera coming off of the pelvic. So the parasympathetic is from the pelvic splanchnic nerves, and the sympathetic is from the sacral splanchnic nerves. And it's basically just going to come forwards and wrap around. It is part of the inferior hypogastric plexus when you're talking about the pelvic organs. Now, areas of consideration for assessment and treatment, because this is a mix of lumbar flexion and lumbar extension, it's just unilateral in this case, where you have side bending and rotation as the things that we're considering. Then what you're thinking about is the erector mass, the lumbar vertebrae, the abdominal wall, the T-spine, generally speaking, the ribs and the hips. So these are the areas. If I tend to identify some change in motion characteristic in these planes and on these axes, then these are the areas that you want to pay a little bit more attention to. But to be fair, once you've found the pelvic motion dysfunction, or the motion dysfunction in the lumbopelvic region, you likely already know where to go, but you're thinking this broadly: erector mass, lumbar vertebrae, abdominal wall, T-spine, ribs, and hips. If you're considering treating the region, then what you want to know as far as red flags are concerned is if there is a known fracture or tear in any of these regions, right? Be it a tear of the abdominal musculature, possibly a tear of an adductor, possibly a tear of the psoas, if it happens to be the case. Then if it's a known tear, you don't treat it. You stay away from that area, because moving a tear can make it worse. If there's a known fracture, you don't treat it, because moving that fracture or putting force through that fracture can interrupt the healing process, or it can generate some more force through the periosteum and possibly make some more disruption to the periosteum or to the bone itself. So you don't treat known fractures or tears. Suspected fractures or tears, you refer out, right? Rebound tenderness in the abdominal wall, because again, pelvic side bending and rotation are generated in the lumbar region. If there's a rebound tenderness of the abdominal wall, you refer out. You don't know what it means, but it could be a visceral pathology. So if there's general tenderness, so tenderness upon initial touch is less sinister than rebound tenderness, which means when you push on it, it doesn't feel any pain, and you let go, you feel pain, or the patient feels pain, then that is rebound tenderness. That's an immediate referral out. Abdominal aortic aneurysms, if you suspect it, because there is some way to detect it externally, which is essentially a larger, like a very, very large bound in the abdominal wall when the patient is in supine, you refer that out. If there's a known aneurysm, you don't treat it. Thoracic aortic aneurysms are much harder to detect. So you're in more of a blind spot there, but if you're in the lumbopelvic region, you're a little bit less likely to impact a thoracic aortic aneurysm. But if you have any reason to suspect a thoracic aortic aneurysm, you refer it out and be careful until you have confirmation that it is or is not there. Most of your anatomical considerations are going to tell you what not to do, and most of your imaging considerations. So if you have an image of a patient that shows some form of pathology, it doesn't tell you what to do. It tells you more so what not to do. So these are the things that we want to discuss as far as being careful. And that is our discussion of pelvic side bending and rotation, with the very explicit note that I am not discussing this region in a way that is consistent with the profession. I am discussing it in a way that is inconsistent for the profession, and providing my rationale such that there is no consistent observation that the pelvis acts independently from one side to the other, or has much motion at all in relation to the sacrum, depending on the source, from 1 to 5 degrees, which is very unlikely to be easily detectable by a practitioner, a hands-on practitioner. In adult female gymnasts, which is a very small population, there's up to 10 degrees of motion of the sacrum between the pelvic bones noted. Very small population, very unlikely to run across these. In most practices, if you happen to be somebody who's practicing exclusively with adult female gymnasts, then maybe this is more of a concern for you. But the pelvis generally is observed consistently across different resources to move more or less as a unit. So I'm discussing it as a unit with my attention on where that motion would be generated, which happens to be mostly the lumbar region.